Hello, everyone. I hope you're having a really nice week whenever you're pulling up to YouTube to watch the video. I'm really excited to have the opportunity to still engage with you in this lecture, even though we're not meeting in person for class on Tuesday of this week. Of course, this lecture is going to be focusing on, as I've mentioned, Chapter 6 as well as Chapter 8, which are our last two chapters within this particular unit before you're getting ready for your first exam coming up next week. So we spent a lot of time last week talking about the various approaches to epidemiological studies. So when we sort of potentially see some sort of outbreak, how do we go about investigating what the potential causes of that outbreak might be so that we can better understand how to prevent future instances? And I have sort of presented all of those studies in the best light that I possibly can without really recognizing that there are a number of problems and limits of epidemiological study that I wasn't able to cover in the course of our conversation. And really, that's the focus of Chapter 6 and Chapter 8. Sort of giving you a sense of, now that you understand what the different approaches are, here's a very real way to approach understanding whether or not those particular studies are valid and accurate and reliable ways to make assertions about what's going on in community health. And so that's where we'll be focusing our efforts. We will have a small conversation as part of Chapter 8 on biomedical ethics as well, which is a really meaningful conversation to be had in the context of the world we live in, where many of us are engaging in our professional livelihoods with patients, and we have to make sure we do so in really ethical ways. And so I want to introduce you to a bit of biomedical ethics. But first things first, let's walk through some announcements. So none of this should be dramatically life-shattering. Much of it is very similar to the things I'd been talking to you about in the week before. I, of course, am not here and you're watching this lecture video. Obviously, you clearly understand, if you're here, that we do have a recorded lecture for Chapter 6 and Chapter 8. I did want to mention, if you didn't catch me noting this in class, that it is actually a two-part lecture, which means that there are two different videos. This is the first video of the two videos, and then there is a second video. I wanted to let you know that that's not for any particular pragmatic purpose. It's simply because these videos are really large. And so for me to be able to upload them adequately to YouTube and also to record them in the ways I am, I needed to split things in half. Really, it's not necessarily in half even. I just have a bit of Chapter 6 that I'm covering in this lecture. And then the other lecture, which is about an hour long, will cover the rest of Chapter 6 as well as all of Chapter 8. Chapter 8 is a very short conversation. So do be sure to listen to both videos. Both will encompass the course of, both class periods worth of conversation, should you be choosing not to come into class on Thursday, as I'll talk about in a second. And so I just wanted to give you a heads up. Don't forget to watch both parts. There is a participation activity that I'll discuss at the very end of Chapter 2. And that's something that you're going to turn in when you return to normal class with me next week. So it is not due Thursday if you're watching this video earlier in the week. It's actually due when we come back together in class next week. So just as a heads up, make sure you're looking for that participation activity, completing it. It's very short, but a meaningful one, and bringing it with you when you return to class next week with me. So just as another really important heads up for those of you who might have missed the many announcements in class, we do have our first exam coming up next Thursday, February 15th in class. That's something that you'll complete in person with me in our normal classroom and our normal time. I do post a study guide for my exams. My promise is always, if it's not on the study guide, it's not on the exam. They're exceptionally helpful tools to use in guiding you towards what you need to know to succeed on the exam. Otherwise, there's a lot of content in these chapters, and it would be very difficult to have it all ready for the first exam. So make sure you're accessing that study guide, make sure you're completing it. And then, of course, the last step I encourage students to do is that if you want me to look at it to make sure that how you've answered questions on the study guide is in a way that will ensure your success on the exam, I am absolutely happy to do so. All you have to do is set up a quick time to meet with me. I'll take a peek at your study guide. I'll chat with you about any things that need addressed differently, and you'll be in a good position to move forward. So at least look at the study guide, complete it, and then if you have time and you feel like it's necessary, set up a time and you and I can look at your study guide together. As I've been mentioning, class on Thursday is an optional session. This coming Thursday, if you're watching the video early in the week, which would be Thursday, goodness, my dates, Thursday, February 8th. You do not have to be in class, but I am actually going to have a health science faculty member come over during our normal class period and sort of monitor the space. If you'd like to use the classroom and the time to work together with other students on your study guide, or you just need a space that's quiet that you can devote an hour and 15 minutes on getting the study guide completed and ready for the exam. Or if you need a quiet space to be listening to the lectures for this week, go ahead and make use of our normal classroom from 2 to 3:15 p.m. on Thursday. Dr. Valvi will be there. He is a biostatistician and epidemiology professor from our department. And so you could also just come and talk to Dr. Valvi. He would love to engage in conversation with students. But he will be there to sort of cover the grounds should any students be present and using the time to work or have any questions that he could help answer. But that's an optional session for you. If you'd like to attend, that's great. And if not, there won't be any attendance taken. Next Tuesday in class, which is February 13th, that is an attendance required review day, which is a little different than the schedule originally laid out. But as you're getting this week essentially off, I am requiring your attendance next Tuesday. It's going to be a cool, relaxed day. Bring your study guide with you. We're going to Kahoot. We're going to review together. I'll be back so that I can make sure you all are in a really good place before the first exam next week. I also wanted to mention that if you have any service learning experience or study guide questions, you're more than welcome to send them my way, even though I'm not on campus this week. I am still 100% available by email. Even though I'm not on campus, that doesn't mean that I'm not accessible. I would point out that it might take me a little bit longer to get back to you. Normally, I'm pretty quick. This week I may take, an extra few hours, or it might be, 12 or 24 hours at max before I get back to you, but I will make sure I follow up. So if you're working on the study guide and you just can't find something, or you don't know if you're defining something the right way, please reach out. And I'm absolutely happy to keep an eye on my email and check in with you until we are back in session, all of us together next Tuesday. So with that being said, let's go ahead and get started with our brief start to chapter 6 for this particular part of the lecture conversation. So as I mentioned, our focus for this week is to really sort of take a deep dive into potential problems with epidemiological study. We spent all of last week walking our way through the various mechanisms by which epidemiologists study outbreaks and disease incidents within populations. As I've mentioned, I presented it in a really positive light. And of course, they are exceptionally powerful research, approaches, but they aren't without their potential issues. And so I wanted to have a very real conversation with you relative to chapter 6 on the problems in some of these studies. It's been a big conversation in the world of public health, especially since the pandemic, that the public is a bit less trusting of public health professionals following some of the ways in which the COVID pandemic was handled. What you're seeing in the image on the screen is actually an article that was published in the New England Journal of Medicine. So this isn't some editorial from some random person spouting off about public health professionals. This was actually published in one of the most premier medical journals in the country. And if you're reading it as you're listening to me, you're probably noticing that that is a pretty, stringent critique of what went on with public health. It says, in many cases, public health leaders stated that they were following science without acknowledging that the data models they relied on have various degrees of accuracy and reliability, that their evidence would require sort of reevaluation after it changed, and that reasonable people could disagree, even academics, about how to translate data into policy. So, we were trying our best as public health professionals to communicate frequently with the public about what went on with COVID, but, to be honest, a lot of people overstated the sort of solid, valid nature of many of their research findings simply to support the policy changes that we were putting forward at the time. And so as a result of that, I think it's really important for us in this class to understand how to look back on the promises that were made during COVID and be really critical consumers of the information that was conveyed to us so that we can ensure in the future that we are sort of preparing ourselves to really be good and solid evaluators of information, especially scientific information that's presented to us. So we're going to talk about a few of the main problems in epidemiological study, and I'll give you some context on each of them as we continue to chat. The first is problems with studying human beings. So what is problematic about studying humans versus other kinds of biomedical research that may be studying animal specimens or models? Secondly, we're going to talk a bit about sources of error and how to be honest about what we really don't know as we're engaging in research. We're going to talk about ways to improve our validity of our studies. And then, of course, as part of our conversation relative to research, a bit on ethical issues as well as how we engage with conflicts of interest. And we're honest about sort of the relationships that drive a lot of our research. So we have quite a bit to get to in terms of this conversation on how we can more critically evaluate epidemiological study. So I should mention before I move too far away from this article that it did get a lot of attention because it was a premier publication from a number of scholars who ultimately made an argument that we weren't necessarily doing a very good job at being honest and truthful with the public about our science during COVID. The article presents this, but then finishes with a really important suggestion that we do a better job of including ethicists in our public health decision making. So, if I'm using public health science or research to drive a decision at the local level, maybe I should also talk to someone who's connected to ethical study to really have them evaluate what are the potential implications of sharing this research and eventually this policy with the public. We also need to do a better job at training our current medical professionals more appropriately so that they can understand as they are creating, implementing, and then also sharing the results of their research, all of the ethical implications that come with sharing those decisions with the public. As soon as you're in a press conference or you're in front of the entire nation talking about a research study that evaluated a vaccine, you have to understand how much power comes with that position. And ultimately, the potential implications of people listening to your message and misinterpreting it, or you not necessarily sharing information in a very honest and true way. So we need to train our professionals to understand the ethical implications of how they go about communicating with the public about their science. And last but not least, and probably the one I think that's most important, even if you're not a public health professional, and many of you are not, and you don't intend to be, we need to train our general public how to be better consumers of all of this information so that when you're sitting in your armchair and you turn on the press conference and it's Dr. Fauci talking to you about the vaccine, you understand the decisions that you are being subjected to and how to interpret the science yourself. Rather than relying on someone else to tell you what went on with the study, can you go to the study itself and critically evaluate it on your own merit to really make decisions that are focused on your own ability to be a critical consumer of all of that information that's put in front of you? You don't need to listen to what other people are telling you, and you don't need to question or you don't need to have this established level of trust if you have the ability to critically evaluate all of it yourself. And so my goal today is to give you some tools to look at these epidemiological studies and critically evaluate whether or not they are valid and true and honest with their science. So one of the first problems that we talk about with epidemiological study is problems with humans. This is something that we largely see in the context of intervention studies in particular. What I mean by that, these are studies where we are, choosing a population of people and having them engage in some sort of programming or treatment option, like taking a medicine or engaging in a workout program or eating a specific kind of diet, and then trying to see if engaging in that treatment leads to a change in the health problem. Interestingly, right, and as common with general human nature, people have a tendency to sign up for things and then they might not follow through with the prescribed behavior throughout the entire study period, right? So, I was closely connected with the campus exercise program. Actually, it was community oriented, ran by campus exercise program, and we were trying to assess whether Zumba as aerobic activity was going to lead to certain health and weight and body composition outcomes with our audience of community members. Unfortunately, we didn't have incentives to offer to our participants to take part in this. It was very much we offer a free class, we offer some education and some food items. You take part, and then we're going to assess certain outcomes before and during and at the end of your involvement in this exercise program. Well, if I'm proposing a class 3 times a week for 3 months that's going to lead to weight loss, what happens if you're a participant who can only come on Wednesday nights? What happens if you attend for the month of January and then you don't show up at all for February and March? We know that humans can be pretty unreliable as research subjects. They drop out, they lose interest, they might not follow up with all of the pieces of a research study. And then ultimately, our findings are a bit skewed because we're only looking at results from those who had some level of commitment to the program, which means that if we implement that in the general public, we might not be able to argue that the results would be found in a generalizable way to everybody. So it's really important to be mindful with epidemiological studies to look for what we call attrition rates, how often someone begins a program or an intervention and then drops out. If somebody touts that they've got 1,000 participants, but only 100 people finished the intervention, then how much can we really say about the merit of that intervention with only 100 participants versus all of those who started? So it's really important for you to keep in mind that there can be problems in studying humans, particularly with their involvement. Another important problem we consider in studying humans are what we call cohort study problems. Now, I walked you through cohort studies last week and what it means to engage in one of these. Remember that in the context of a cohort study, we're trying to understand the determinants of specific illnesses within certain cohorts of people. So we're sort of looking at groups of people who aren't necessarily at the time exhibiting some sort of disease condition, but differ in some other kind of way. And then we're going to track them over time to see if they end up developing a disease condition. And if we can see marked differences between the original two cohorts, then we could say that there might be a predetermining factor. So in this case, you can see, as we've talked about, almost 120,000 nurses had no cancer, had no heart disease. We had a group of them who were considered obese. We had a group of them who were considered lean and not obese. And then we tracked them over time to see if they ended up having a heart attack or if they ever developed cancer, to sort of assess whether their weight status had a relationship with their heart disease or their cancer diagnosis. Now, I can tell you in this study, we're paying attention to this difference based upon weight status. But with cohort studies, it sometimes can be hard to isolate which two factors of a whole lot of factors could be responsible for these health differences. I might set apart these two groups based upon weight status, but at the end of the day, the difference between those who had a heart attack and those who didn't might connect to weight status, or it might connect to something very different. Maybe these women are in more stressful positions at their job, and we know stress contributes to, heart attacks. Maybe these women have a pre-existing family history that we didn't assess because we were so focused on the difference between those who were obese and those who were more lean. And so there are many cases in cohort studies where we overlook really important pre-existing variables because we're focusing so closely on what separates two cohorts. So it can be a little difficult at times when we're studying individuals in a cohort context to really isolate which of those factors are the ones that actually contribute to the issue. Could the women have lived in communities where they were exposed to certain kind of cancer-causing agents? We don't always know that, and so it can be very, very difficult with cohort studies to really isolate which factors differentiating a cohort have led to the incidence of some health issue. Another common problem with humans also happens in our counterpart to cohort studies, which are case control studies. Now, remember, a case control study, different from a cohort study, compares people with a specific health condition to those who don't have it. So we start with people who have the health problem and then try to look back in history, right? Go back in what they've done to see if we can figure out where there's a difference between those who have cancer and those who don't. Remember, a cohort study is separating people based upon the characteristic and then looking at them over time to see if they get the health problem. A case control study is starting with those who have the health problem, comparing them to those who don't, and then going backwards in time to see if we can find the cause. Now, the problem can be with case control studies that our control group actually may not be truly comparable to our case group. For example, what if there are other and more important differences between our groups than the cancer diagnosis? We're obviously separating out those who have the issue with those who don't, but there could also be a variety of differences between these two groups that could be leading to the actual, health problem taking place. And so if there are other and more important differences between the groups, then we might completely be, off in our assessment of why they're sort of having this pre-existing history that's leading to them developing the issue. I think the most significant problem with case control studies, though, are errors in recall. It is really difficult for me to remember what I had for breakfast 2 days ago. It would be very difficult for me to remember what I've been exposed to in every place I traveled to and what doors I touched or didn't touch in the last week. I would have difficulty in doing that. I'm sure you all would too. So, in this kind of study where we're looking backwards and seeing what people's exposures were, we have to ask people for histories. And can we recall everything that we've done that might have led us to eventually now have cancer? That's really doubtful. So, when we're actually doing case control studies and looking back in time, we have a problem with recall. We have recall bias and we have difficulties with individuals potentially not reporting on a history that could be really significant to the condition they have at that time. I had mentioned a few slides ago the context of the problem with humans staying committed to research programs. And I will tell you that this is one of the most significant issues in public health intervention research and really a lot of biomedical research in general. With every kind of study, when you're involving human participants, dropouts are really problematic. Consider the fact that 30% is our average dropout rate across all clinical trials. And I'm sure you all know medications and treatments are decided based upon clinical trials. And yet, over a quarter of the people who get started in a clinical trial just give up and drop out. That's a lot of financial burden as well as some difficulty with research validity. On average, it costs over $6,000 to recruit someone to one clinical study. The average cost to recruit somebody new, if somebody stops attending, increases upwards of close to $20,000, which really speaks to how important it is to think about this problem of retention. How do we get people to try these treatments and stay committed throughout the course? Because that's the only way we can really have legitimate research results for many of these studies. So it's a really expensive endeavor as well. I want to sort of transition from this context of human problems to talk to you a little bit about other sources of error in our studies. This is something that's more so connected to how we approach analysis than it is necessarily human intervention. One of the biggest problems that we have in our research studies across disciplines is what we call random variation. Consider the differences in an outcome that could happen based upon chance rather than anything being studied. There's always that possibility that someone may end up getting cancer regardless of what we were paying attention to, or someone may end up having a pre-existing history with something that isn't at all what we anticipated, regardless of what our focus is. The potential for random variation and results just due to chance is always present. We had to consider this often with our exercise program. There could be women who lose weight, and really we don't have a good explanation for it, and it might not connect at all to their participation in our exercise program. Keep in mind that even though the chance of getting heads or tails when flipping a coin is 50-50, right? You got 50% of the time you're going to get heads and tails because that's the way a coin's crafted. There could be times, and there will be, where you flip the coin 10 times and you're going to get heads a bunch more than what you're going to get tails. 9 times out of the 10 you could. And that's just what random variation is. So the point of that, and the way we engage with that question in our research, is to have really big samples of study participants. You don't have as much of an influence of random variation if you're studying a lot of people. So the argument is have a really big sample and also look at people for longer periods of time. That also can reduce statistical random variation and its influence on your findings. So keep in mind, some things can just be due to chance, and we have to be mindful of that potential as epidemiological researchers. One of my last conversations that I want to have with you for this first part of our lecture slides relates to another factor called confounding variables. And I have an interesting example to share with you to highlight what I mean by a confound. For a very long time, research had established, and we had strongly believed that alcohol use was a significant contributor to the development of lung cancer. If you look back at research on lung cancer from earlier parts of the 60s and the 70s, we were really focusing hard on this notion that heavy drinkers commonly were showing cases of lung cancer. However, it took some time before we actually started to ask the right questions of many of our lung cancer patients relative to their drinking behaviors. Specifically, many of you probably know someone who also smokes when they drink. It is a relatively common comorbidity. That's a term that just means sort of two things that happen at the same time. If you've got someone who's a heavy drinker who's likely also smoking while they're drinking, how do you disentangle which of those two factors was the largest contributor to their development of lung cancer? What we've come to understand is that alcohol consumption is a confounding variable in the relationship between tobacco use and lung cancer development. Often it's the case that we have this additional variable that has the ability to alter the results and the strength of the relationship between the cause and the outcome in really interesting kinds of ways, because these two behaviors often happen together. Not always, of course, but in many cases they do. And so, with increased study, when we started to actually look at individuals who were uniquely smoking, who also weren't drinkers, and those who drank but weren't also smoking, asking that important question, do you do them together? We started to see that the relationship was stronger for tobacco use than it was for alcohol use. But for years, alcohol was considered an important factor. It really confounded the relationship between smoking and tobacco use and lung cancer because it was this additional external variable that seemed to weigh in a way that we couldn't necessarily understand until we took out the confound from our consideration. So confounding variables are really important to consider when it comes to ruling out the potential of other factors in the strength of the relationship you're seeing between a cause and an effect. So that's it, my friends, in terms of my start to part one of your lecture. Please, please, please don't forget to go to part two, which is going to talk about much more chapter 6, some really cool stuff on biomedical ethics, and then a quick conversation on data as part of chapter 8. Don't forget that you also have a participation activity that's mentioned at the very, very, very end of that set of lecture slides. Now, I know some of you are probably thinking, I'll just go watch part 2 and finish the participation activity and move on. But I do forewarn you, there are a number of questions on this first exam from these 2 lectures. So do yourself a favor and actually sit through this and take some good notes, because it'll benefit you as you're working on the study guide for sure. I wish you the very best of luck in getting ready for next week's exam. Please let me know if I can help. If you'd like to make use of the classroom space on Thursday the 8th to work, it's absolutely there for you to make use of. Otherwise, if you choose not to, I will see you all together with me again in class on Tuesday, February 13th. Y'all have a very, very good week.